السلام عليكم ورحمة الله وبركاته. Good day everyone. أنا البقمي. I'm a 5th year medical student from Imam Mohammed bin Saud University. I'm going to present to you body fluids, electrolytes and acid-base disturbances. هذه محاضرة تنعطى بالسنة الرابعة بالsurgery rotation. So the objectives معنا اليوم you should know the normal fluid distribution within the body, recognize the signs and symptoms of changes in the fluids and electrolytes and nutrients. You should know the causes and the clinical consequences of different disturbances in the fluid, electrolyte and acid-base balance, and understand the goals of treatment. كل هاد disturbances. You should know the common IV fluids also. So starting off, water constitutes approximately 50 to 60% of the total body weight. So knowing that, the fluid with electrolyte management is really important to the care of a surgical patient. Both the fluid volume and the electrolyte composition occur operatively and intraoperatively and post-operatively, even in the response of the trauma and sepsis. So we should balance the input and output of the fluids. What gets in should get out. تمام? Any fluctuation, even 5 to 10%, can have a serious impact on your health. Depending on the amount, it can lead to impaired cognitive function, headache, fatigue, dry skin, hypovolemia, shock, organ failure, and even death. So it's a balancing act. You should balance the fluid. The amount of water gained each day equals the amount lost. Electrolyte balance, the ion gained each day should equal the ion being lost. The acid-base balance, which has to do with the pH balance. So what is a negative fluid balance? Is when the output is greater than the fluid intake. So there is an insufficient input. A positive fluid balance is when the fluid intake is greater than the output. So there is insufficient output. مثلا the kidneys are not excreting enough urine. So if urine, there's fluid overload. And in the negative fluid balance, I am excreting more than I'm taking in. So زي ما قلنا, the body weight approximately 60% is water. 2/3 intracellular, inside the cell. Intracellular fluid, and 1/3 is extracellular fluid. So as you can see here, extracellular fluid constitutes intravascular, which are inside the vessels, and interstitial tissues. So in the extracellular, you have mainly sodium, magnesium, calcium, potassium, and in the intracellular you have a low sodium amount, and you have calcium, you have high potassium, but you have low chloride, okay, and low bicarbonate. So في cations, في anions, and we're going to repeat that again. In the extracellular fluid, قلنا the main chief cation is the sodium, and the chloride and the bicarbonate are the anions. Albumin, there is also albumin. It is the primary molecule responsible for the oncotic pressure generated by the extracellular fluid. Aldosterone and the antidiuretic hormone increase the extracellular fluid by increasing the salt and the water reabsorption. أما ANP decreases the extracellular fluid, فهو عكس الالدوسترون والADH, okay, by promoting the salt and the water excretion. So they are balancing each other basically. The intracellular fluid, the main cations are the potassium and the magnesium. The phosphate and the sulfate are the anions. We have proteins, but we have low sodium and chloride, as I just mentioned. So why is this important? You may ask. Because any disturbances in these electrolytes will have major effects on your body. In the CNS system, hyponatremia can even cause coma, seizures, headaches, confusion, even major cardiovascular effects, bradycardia, hypertension, and it increases significantly. In the hypernatremia, you will notice lethargy, ataxia, irritability, and also seizures and coma, weakness, tachycardia. In the renal system, you will notice oliguria, fever. So you should monitor and observe the patient for all of these symptoms. Also, potassium has major effects on the heart. It could even cause cardiac arrest, and also the calcium amount. And you should review all of these symptoms by yourself. Fluid correction. It says that you should replace the water and the electrolyte as determined by the patient needs. But there is an important thing here. If you're going to correct a chronic hyponatremia, you should do it gradually over 48 hours to avoid something that is called central pontine myolysis. And this is really fatal, and a lot of the time medical errors are being made. They correct the hyponatremia too fast, and the patient goes into a coma and never wakes up. The fluid balance in resuscitation. So a total requirement is basically maintenance plus the deficit plus the ongoing loss. So it's not set and forget type of situation. You have a maintenance, but also you should assess for if there is any losses. If there is increased dehydration, you have to calculate it by the deficit. And also, if you're giving blood products, you're giving medications, subtract that from the total requirement. فهنا يقول لك in surgical settings you should account multiple factors زي ال preoperative fasting and decreased fluid intake, increased losses during or before the surgery, fluid shifting during surgery, fluids given with blood products and medications. An average healthy adult requires approximately 2,500 milli of water daily. تقريبا لتر ونص you take it from oral hydration. Even the food في نسبة موية 500. Metabolism gives you 500, so in total 2,500. And you lose approximately لتر ونص بالurine, and the GI system you will lose 200, and in the respiration you lose 800, and it's all balanced. Whatever gets in gets out. So calculating the maintenance, في شيء اسمه ال 4-2-1 rule. This is for calculating how much fluid the patient needs an hour. And there is the 150 rule, which calculates how much a patient needs fluid per day. تمام? It's easy. Once you understand this rule, you will never forget it. So it says, in the first 10 kJ, you get 4 milli kJ per hour. In the second 10 kJ, you get 2 milli per kJ per hour. And in the remaining weight, you give 1 milli. We will practice together. So here, if I told you have a 7 kJ infant, since this infant is in the first 10 kJ, you multiply that by 4, since it's 4-2-1 rule, and it gives you 28. So this infant gets 28 milli per hour. If you want to calculate it daily, you can multiply that by 24 hours, but to be more accurate, there isn't much difference. But basically the 150-20 rule, you multiply that by 100, since we are still in the first 10 kJ, and you get 700 milli daily. Let's try that on a bigger person. 75 kilogram male. The 10 kilograms get 4, so 10 times 4 is 40. And the second 10 kilograms get 2, so 10 times 2 is 20. And the remaining weight is 55. And it gets just 55 because we multiplied it by 1. And adding the 40 and 20 and 55, you get a 115 milli per hour. Calculating per day, same thing, but with 150-20, you add all of these and you get 600 milli daily. In a 15 kilogram child, the first 10 kJ gets 4, so 10 times 4 is 40, and the remaining is 5. So we're in the second 10 kilograms, so 5 times 2 equals 10, so you get 50 milli per hour. Same thing with the 150-20 rule. You multiply that by 100, you get 1,000. You multiply 5 by 50, you get 250, and this patient gets 1,025 ml daily. So you have signs and symptoms of dehydration, okay? And these it differs in severity, and the symptoms reflect the percentage that is being lost. So if you lose 3%, this is mild, you will notice decreased skin turgor, sunken eyes, dry mucous membrane, dry tongue, reduced sweating. If you lose 6%, this is moderate, you will notice oliguria. The kidneys are trying to maintain the fluid, so not much urine. Orthostatic hypotension, tachycardia, low volume pulse, cool extremities, reduced filling of peripheral veins and CVP, and hemoconcentration and apathy. If it's 9%, this is extremely severe, profound oliguria, anuria even, and compromised CNS function. Once it affects the CNS, this is extremely severe. It will cause confusion, altered mental status, and such. So this is basically showing you the effects of volume deficit and the volume excess. This is too little fluid and too much fluid. In the deficit, you see weight loss, decreased skin turgor, tachycardia, orthostatic hypotension, collapsed neck veins, oliguria, azotemia, and ileus. In the volume excess, you notice weight gain and edema, increased cardiac output, increased central venous pressure, distended neck veins, murmurs, bowel edema, and pulmonary edema. So deficit and excess, هذا يعني إنه there will be increased requirements إذا في loss. With fever, sweating, GI losses, adrenal insufficiency, and hyperventilation, and polyuric renal disease, you will need more. You will have increased requirement. You will have decreased requirement when there is anuria or oliguria. Why would you give fluids if the patient is not excreting the urine very well? You will override the patient. If they have SIDH, inappropriate ADH production, highly humidified atmospheres, or congestive heart failure, why would you overload the heart with too much fluid? So in hypovolemia, there are multiple types. There's the extrarenal sodium loss, happens in the GI, like in vomiting, in nasogastric suctioning, drainage, fistula, diarrhea. In the skin and the respiratory, there's insensible losses, like fever, sweating, and burns. Burns patients need a lot of fluids. In hemorrhage, بالنسبة للrenal sodium and water loss, that happens with diuretics, osmotic diuresis, hypoaldosteronism, and salt wasting nephropathies. Renal water loss, diabetic insipidus, سواء central أو nephrogenic. Hypovolemia with normal or expanded extracellular volume, this indicates there is a decreased cardiac output. There is redistribution kind of hypovolemia, hypoalbuminemia, like cirrhosis, nephrotic syndrome, and capillary leakage, like in acute pancreatitis, rhabdomyolysis, ischemic bowel, sepsis, and anaphylaxis. So, in ongoing losses, what do you mean by ongoing losses? If there is losses in the urine, like in the Foley catheter, nasogastric suctioning, surgical drains, third spacing, losses بالبلورا بالGI بالretroperitoneal بالperitoneal. Sometimes if you have an open wound or burns, there is evaporation of this fluid, so it should be accounted for. If there is blood loss, if there is ongoing, زي ما قلت, surgical exposure will evaporate. Intraoperative losses, blood loss, they say that's usually underestimated. Usually يعني you can assess it by just looking visually, inspecting the drapes, suctioning, لأنه في suctioning tubes, and they say that you can weigh the sponges that are loaded with blood, and each gram equals 1 cc of blood. So of course after you subtract the dry weight of the sponge itself. So this is like, it tells you exactly how much is being lost and how much you should give the patient. Third space loss refers to the loss of the plasma fluid into the interstitial space as a result of tissue trauma, and can be estimated based on the nature of surgery. مثلا أنا دخلت البيشنت surgery orthopedic ما فيها blood loss كتير, you will probably just need 2 to 5 cc. If it's moderate surgical trauma like bowel resection and such, you will need more. You will need 5 to 10. If there is major surgical trauma, you will need 10 to 15 maybe. So how do you assess the fluid status? Well, you should always monitor the urine output. If it's 1, this is reassuring, and this is an indicator of adequate organ perfusion. If they are hemodynamically stable, the oxygenation تمام, the pH تمام, central venous pressure are okay, this is good indicators of the volume, as I just said in this picture. Coming to the IV fluids. So there are 2 types of IV fluids. There are the crystalloids and there's the colloids. The crystalloids are what we know, يعني اللي نعرفها normal saline, ringer lactate, D5W. طبعا هنا يقول لك إن IV fluids improve perfusion but not the oxygen carrying capacity. الشيء الوحيد اللي يحسن من الأكسجين هو blood products, of course. This is just to improve the perfusion and hydrate, of course. Crystalloids, they are salt-containing solutions that distribute only within the extracellular fluid. So they say if you lose 1 milliliter of blood, give 3 milliliter of crystalloid infusion. So this is a 3-to-1 ratio replacement. هنا يقول if you are giving large volumes of IV fluids, make sure it's Ringer's lactate or plasmolite, because if you give too much normal saline, that would lead to hyperchloremic metabolic acidosis. كيف? Because you need to know the composition. As you can see here on the third row, a normal saline has a pH of 5. This is low, and that's why it could cause metabolic acidosis. And also look at the chlor level is 154. So this is why it would cause hyperchloremic metabolic acidosis. And unlike the Ringer's lactate, as you can see, it is balanced in the electrolyte. ما راح يسوي لي dilution. بيوازن لي ال pH, and it's overall a better choice. Even the plasmolite. So here it says that ultimately only 25 to 30% of the volume administered remains intravascular. يعني أنا لما أعطي patient crystalloid تقريبا خلال 15 لنص ساعة أكثر من نص بيدخل الجسم, بيروح من الباسلز. That's why this should be accounted for لما أنا أعطيها بالريت. الريت لازم يكون محسوب وموزون صح, لأنه in a short period of time it's gonna go inside the cells and redistribute. Unlike زي الحين بقول colloid infusions. Colloid infusions are protein colloids and non-protein colloids. They distribute within the intravascular volume. They have a 1-to-1 ratio. مو زي الكريستالويد 3-to-1 ratio. If you lose 1, you give 1. Okay? They're usually of either starch or gelatin in origin. Initially, they are largely confined to the vascular compartment. مو زي الكريستالويد, they in خلال نص ساعة they go out of the vascular compartment. هنا يقول لك ال HES colloids remain in the intravascular space, metabolized by the plasma serum, amylase, and renally excreted. The use of colloids is generally reserved for cases with greater than 20% of blood volume needs to be replaced. فإن أنا خسرت كثير blood ما راح أعطي crystalloid. I will prefer a colloid infusion. Okay? Because ليش? Yeah, because الcrystalloid might cause interstitial edema. Coming to the blood products, we have packed RBCs, platelets, fresh frozen plasma, cryoprecipitate, and whatever your patient needs or lacking, you give them to it. Of course, before a transfusion, you should ask yourself a lot of questions. Does the patient consented? Did the patient consent? If anemic, Is this an acute anemia or chronic anemia to the patient, which the patient has adapted? Is the patient likely to lose more blood in the immediate future? Does the patient have risk factors for atherosclerosis, coronary artery disease, or cerebral vascular diseases? And also, is there evidence of coagulopathy in which additional blood loss is anticipated? Does the blood loss exceed what was calculated as the acceptable blood loss for this patient? Is the patient hemodynamically unstable despite other fluid resuscitation? This all should be accounted for. Packed RBCs are given to maintain or restore oxygen carrying capacity. هنا يقول as the hemoglobin concentration falls, the oxygen delivery بينقص طبعا. There is a compensatory mechanism that is happening in the heart, لأن the heart is because you are lacking oxygen, the heart works too hard, increases the heart rate, and increases its contractility, so the oxygen reaches the cells. This is really exhausting for the heart. That's why anemia hurts the heart, basically. When these compensations are inadequate or detrimental, we should give RBCs. Okay? And هنا يقول الهيموglobin in the range of 6 to 8 are now considered acceptable in patients who do not have cardiovascular diseases. أما الهيموglobin in the range of 10 is the cut-off for transfusion for any patient suffering from cardiovascular diseases. So زي ما قلت, if you are lacking something, give them. Oxygen carrying capacity, give red cells concentrate. If you're lacking platelets, so in quality or quantity, give platelet. If you're lacking clotting factors, give the fresh frozen plasma. Sometimes in hereditary diseases you lack one clotting factor, just give them this factor concentrate. If you're lacking fibrinogen, give cryoprecipitate. A low protein or colloid volume replacement, you give albumin, basically. So of course, as we all know, blood transfusions have a lot of complications. من aeroembolism, من hypothermia, circulatory overload, allergic reactions اللي تصير, febrile reaction, أنواع infections, immune suppression, and such. So coming to the acid-base balance, this is an easy topic once you grasp it. بتاخذونه كثير, أكيد قد أخذتوه قبل, بس بنتعمق أكثر هالمرة. So intercellular pH is tightly regulated. There is several buffering system minimize the change in the pH that are associated with the addition of acid or base. فدائما جسم الإنسان يحاول يعادل هذا pH في الطبيعي, تمام, في buffering system. يعني إيش؟ عندنا البيكربونات والكربونيك acid هم ضد بعض in بالبلازما and interstitial fluid. Bicarbonate is the major buffer, تمام, with proteins and phosphate compounds contributing to a lesser extent. Erythrocyte, there is the hemoglobin is the major buffer with bicarbonate and also phosphate, and also the secondary and tertiary compensation for the underlying acid-base abnormality occurs via the lungs and the kidneys. We'll get to this shortly. So many critical illnesses can disturb this acid base, and from monitoring this acid base disturbance we can know which disease is causing this acid base disorder. So you will know, they will give you arterial blood gases and plasma electrolyte, and you should have knowledge of the compensatory physiological mechanisms to reach the result. تمام? So here you have the normal pH range, which is from 7.35 to 7.45. If you have إذا في حموضة فهذا acidosis. إذا في قاعدية أكثر, this is alkalosis. Okay? مين يتحكم مين يرفع الأسيدوسس؟ مين يرفع الحموضة بالجسم الإنسان هو CO2. تمام? Which is associated with the respiratory system. مين يرفع القاعدية هو البيكربونات, which is associated with metabolic. تمام? So there is balance between them two that keep you in a normal pH. So زي ما قلت acidosis is 7.35 and alkalosis is more than 7.45. So we have 4 primary acid-base disorders. We have the respiratory acidosis, we have respiratory alkalosis, we have metabolic acidosis and metabolic alkalosis. And a lot of the time, there are compensatory response to trying to restore this pH towards the normal. The kidneys compensate for primary respiratory disorders. The lungs compensate for the primary metabolic disorders. فإذا أنا عندي مشكلة metabolic اللنجز إذا عندي مثلا البايكربونات عالي أنا عندي قاعدية بجسمي the lungs will hypoventilate عشان ترفع لي CO2 عشان يعادل البايكربونات العالي. Okay, the kidneys also do the same thing. If I have مثلا asthma or COPD, CO2 عندي عالي, the kidneys will try to retain ترفع البايكربونات عشان compensate الحموضة اللي قاعد تصير من COPD أو الأزمة. These are the normal values. You should I don't think you should memorize them, but you should memorize the onion gap formula. So each primary disorder has its differential diagnosis. فهنا يقول respiratory acidosis زي ما قلت COPD, any lung damage, airway obstruction, any inhibition of the respiratory. Okay, metabolic acidosis happens in diabetic patient, diabetic ketoacidosis, diarrhea, renal tubular acidosis, ingestion of acid, chronic renal failure. In respiratory alkalosis, this happens a lot in people with panic attacks who hyperventilate. So when they hyperventilate, CO2 lowers in your body, that makes alkalosis in your blood. And that's why they tell people who have hyperventilation or in panic attacks to breathe in a bag to raise the CO2 level. In metabolic alkalosis, there are a lot of causes, most importantly, vomiting. A lot of the time it comes in MCQs. Vomiting, diuretic use also. And ingestion of alcohol, of course, drugs, all type of stuff. Here it's a cute picture. It can help you maybe remember, but it's the same thing. Here there's a good mnemonic for remembering a metabolic acidosis. Dr. Carmel. So in metabolic acidosis, you can have either diarrhea, if it's a normal onion gap. We'll get to the onion gap in a while. Diarrhea, renal tubular acidosis, ketoacidosis, aspirin, renal failure, methanol, ethanol, and lactic acidosis. In metabolic alkalosis, زي ما قلت, most importantly, diuretic use, vomiting, any decrease in glomerular filtration, increased bicarbonic reabsorption, and there is no way out. You have to memorize them. Okay. Same thing here. In respiratory alkalosis, you have like panic attacks. I just said pulmonary embolism, pneumonia, asthma, pregnancy, pain can cause this, sepsis, liver cirrhosis, drugs, restrictive lung disease, and overaggression, mechanical ventilation. In the respiratory acidosis, basically زي ما قلت COPD, asthma, pneumonia, anything that is restricting ventilation. So this is showing you the primary changes in each primary acid-base disorder. In metabolic acidosis, you have lowered bicarbonate. In metabolic alkalosis, you have high bicarbonate. In respiratory alkalosis, you have high CO2. And respiratory alkalosis, you have low CO2. So coming to the first case, you have a 2-year-old child who is lethargic and dehydrated. He has a 3-day history of vomiting. This is the first clue, vomiting. His ABG showed a pH of 7.56. this is high, this is alkalosis. So now you know, this is alkalosis. CO2 is 44. So this is normal. CO2 is normal. Okay, so it doesn't go with this. Bicarbonate is 37. 37 is high. So I'm guessing this is metabolic alkalosis. Since the bicarbonate is high and the CO2 is normal, and this the bicarbonate goes with the pH value, basically. A patient known to have COPD presented with a 3-day history of fever, shortness of breath, and cough, productive of yellowish sputum. So you already know this is respiratory. pH is 7.2. This is acidosis. This is low. And CO2 is 80. This is really high. This is high. And bicarbonate is 34. So which value? CO2, bicarbonate is low. So which value goes with the pH value that we have? We have acidosis. What goes with acidosis? CO2. So we have a respiratory acidosis. And it's also compensated because the bicarbonate is high. So that's why it is compensated by the kidneys to try to balance. But even though it is not high enough to make the pH normal, so this is respiratory acidosis with compensatory metabolic alkalosis. Sometimes you have acid-base disturbances mixed. So can you get respiratory alkalosis مع metabolic alkalosis? Yes, you can. Can you have them happening simultaneously? Yes, you can. How can you differentiate? We will get to this. With this case, a 69-year-old patient had a cardiac arrest soon after return to the ward following an operation. Resuscitation was commenced and included intubation and ventilation. Femoral arterial blood gases were collected about 5 minutes after the arrest. The anion gap is 24 and lactate is 12. Okay, pH is really low. pH is 6.85. So I already know this is acidosis. Bicarbonate is 82. This is high. So it can go with respiratory acidosis. Bicarbonate is 14. It is low. It also low. So it can also cause with metabolic acidosis. And you guessed it, this patient has both. They have a metabolic acidosis with a respiratory acidosis. They are working together, lowering the pH level. As you can see here, the primary change, they're both strong enough. So here in case 4, the arterial blood gas showing a pH of 7.38. So this is normal. You may say, why do we bother? Well, look at the CO2. CO2 is 22. And the bicarbonate is 12. So the bicarbonate is low, with CO2 is also low. So what is happening exactly? Let's see. It looks like they're working against each other, causing a normal pH. There are 2 acid-base disorders opposing each other. So let's see here. Let's look at the primary changes. Something that is lowering the bicarbonate and also lowering PCO2. And you guessed it, it's the metabolic acidosis and respiratory alkalosis. Exactly. Metabolic acidosis with respiratory alkalosis working together against each other, causing a normal pH level. So now we want to get into the calculating the anion gap. The anion gap is calculated by sodium minus the chloride plus the bicarbonate. Why is this significant? Well, it tells you know the differential diagnosis. Each acid-base disorder have either high anion gap or low anion gap, and that can help you know what is causing the patient's acid-base disorder. So here we have in case 5, a 58-year-old man presents to the emergency department with abdominal pain and hypotension, and he is diabetic. Okay, diabetic. And atherosclerotic investigations reveal the following. Analyze the acid-base disorders in this patient. Well, after calculating the anion gap, it is 55, and this is high. And also looking at the pH level is 6.8. For 6.8 is low, so this is acidosis. And let's look at the bicarbonate. It's 5. This is low. CO2 is 36, so it's normal. But this is obviously a metabolic acidosis with a high anion gap. So what are the diseases that cause high anion gap metabolic acidosis? Okay, renal failure, lactic acidosis, and ketoacidosis. And that's definitely right. Because he is atherosclerotic, he developed ischemia, which caused lactic acidosis. And that's why you should memorize the differential diagnosis because it helps you know the causes. There's something else that is a bit advanced. You can calculate the respiratory compensation if it's required, of course. When there is a change in the level of bicarbonate, of course the lung will compensate by changing the respiratory rate, which will change the CO2 level. As we said, in metabolic acidosis, CO2 decreases by 1 for every 1 decrease in the bicarbonate. أما بالmetabolic acidosis, CO2 increases by 0.6 for every 1 increase in the bicarbonate. But there is this formula that is called the expected CO2. So now يكون عندي مشكلة metabolic, you are expecting the CO2 to respond, of course. But it is calculated by this formula, 1.5 times the bicarbonate plus 8. And the value that you get is the expected CO2. When a patient is not presenting with an expected CO2, that means there is a respiratory issue that is preventing the patient from compensating. And what does that even mean? That means the patient has another acid-base disorder, a respiratory acid-base disorder, causing that they can't compensate. Okay, coming to case 6. A 56-year-old male with history of COPD is admitted with a 1-week history of dyspnea, productive cough, and diarrhea. These are the electrolyte, and looking at the pH, 7.14. He's in acidosis, and the bicarbonate is 10. It is low, and the CO2 is a little bit low, but not as low as the bicarbonate. So this makes me think it is a metabolic acidosis. So let's calculate the expected PCO2. So it is 23. Why isn't the lung fully compensating? It is only 30. It should be 23, more or less. It is because there is an underlying primary respiratory acidosis caused by an underlying disease, which is, you guessed it, COPD. Calculating the anion gap, it is 12, which is normal. Most likely, the cause of the metabolic acidosis is the diarrhea. And this is it for the lecture. Thank you for bearing with me. This is my references, and also I took the cases from the internet. For credit to whoever who made them. If you have any questions, you can ask in the comment section or email me at nuhamg@gmail.com.